Good morning and welcome everyone in today's CCR. Respected Emeritus Chairman Sir, our Pro VC Sir, VC Sir and other dignitary. As a protocol of CCR, let me start with the introduction of my department to all of you. Department of Cardiology get established in June 2012 and this was the first super specialty branch which was started in Mahatma Gandhi Hospital. And our DM Cardiology program started in 2019 and every year 4 students get enrolled in Department of Cardiology. And other than me, we have 3 consultants, Dr. Dipesh Agrawal, Dr. Rajiv Sharma. Let me first start with what facility and infrastructure we are having. For that, we divided into 3 groups, OPD, IPD, non-invasive cardiology and invasive cardiology. This is the gateway of our department. Apart from routine OPD, we are running lipid clinic, pacemaker clinic and CHF clinic. And now we come to the main in-house, which is called CCU. We have 20-bed CCU, totally equipped with all support system. A number of bed in ward is 12. Total number of bed in cath recovery was 12. Occupancy rate is almost 90 to 100% every time. Support system in the form of we have central monitor, so that one person can look after what is happening inside patient electrically in all patients. And other than that, we have electrical support in the form of TPIs, defibrillator, mechanical support in the form of intra-aortic balloon pump, respiratory support, and 24-hour availability of echocardiographic machine. Now we come to the non-invasive facility. We have 10 dedicated EC machine for our department, 3 Holter machine, TMT was 1, and 3 latest echo machine was in our department, and it was EPIC 7C. They are equipped with transesophageal probe, and now we also having latest software in the form of tissue Doppler, stain imaging, and live 3D. Which were live 3D. Now we using some type of doing some type of complex cases in our practice. This is the last year 3-year data of our department. OPD in OPD number in last 2022 was 17,947 and which increased to 18,836 in last in 2024. Per day, every OPD sir. OPD in last nearly 200. This is a come on. And now we come to the invasive cardiology part. We have for 3 well-equipped cath lab, and all 3 cath lab are fully. The first one is Philips FD10, second was Philips FD20, and Philips 3M 12 Azurian was last add on our department. All 3 stent have 3 stent boost facility. We can see that after stenting, if we want to look after what is the expansion of a stent, we can easily visualize. And if we see such type of picture after a stent, we are okay with that. And in 2 cath lab, we have facility of 3D reconstruction, and 1 cath lab having simultaneous CT scan. So sometimes patient develop CVA on the table, and we can easily not. In that cases, we have not sent to the CT scan machine, and we can easily diagnose in the table, and we can manage according to that. And there is also facility of roadmap facility in last cath lab, which is usually mainly used by our intervention radiology colleague and neurointervention colleague. These are all 3 cath lab. What spectrum of work we are doing routinely? For that, we divided into 5 groups: coronary angiography and angioplasty, valvular, structural, endovascular, pacemaker, CRT, and others. Some of the cases were done first time in this center, where they were also the first time in our country also, and they get reported in some international journal, and all the cases were all the landmark for our center. First, that coronary angiography and angioplasty is the main routine work in our center. This is the case of normally, apart from normal coronary angiography, we also do angiography of post bypass graft, which is usually a complex procedure. In this case, we can see 3-year back patient underwent bypass surgery, but 1 month back he came with chest pain. Later we can easily see the graft artery get occluded, and that later open with angioplasty. Now we come to the endovascular. Usually after establishment of intervention radiology and neurointervention, such type of cases directly go to their department, but when such type of cases came in our department, we also treat them. It's by like endovascular, sorry. This was like case of aortic aneurysm. This was also like patient came with post angioplasty. This case came with TIA. This after carotid stenting. This look like that. This was this is patient of post angioplasty came with hypertension. That later on renal artery stent was done. Now we come to the valvular. Most of the cases which doing valvular as a balloon mitral valvotomy, this is mainly done in medical colleges because usually patients such type of poor and this type complex procedure is always usually underwent in medical colleges. So almost every month we get 5 to 6 cases of balloon mitral valvotomy in our center. In last 3 years, if you look at the data, in 2022, in 2036 cases of angiography was done, and in 2024 it increased to 2,866. Similarly, in 2022, 1,288 cases of angioplasty was done, and that increased to 1,788. And number of ablation procedure was done in 161 in 2022, but increased to 306 in 2012. These are the structural pacemaker. We are doing. We are all doing all device closure of ASD, VSD, PDA, and also different type of complex AICD procedure and CRT procedure in our center. Now we come to the add-on advanced technology, which are add-on in our department. And first is actually most controversial and confusing aspect of cardiology is what to do even after angiography, because sometimes we do angiography and we don't know what to do after angiography because lesion are not significant. Somebody say it is significant, somebody say not significant. In this case, such type of situation, what to do next? So 3 years back in our department, add-on treatment, add-on facility like FFR was added in department. That after putting the pressure bar in the coronary artery, we can easily decide what to do or not to do. So this is recent add-on facility in our department. Next is FFR. Actually, angiography is what? We insert the dye in the blood vessel and see the lumen of the blood vessel. But if we want to see outside of the blood vessel, we are nowhere. For that facility, department added intravascular ultrasound in 3 years back. In this machine, apart from lumen, we can also see outside of lumen, and this is different. This is a picture. You can see this is like torch. If we see the only path, this is called angiography, and if we want to see beyond the path, like what is the outside of the blood vessels, this is called intravascular ultrasound. So in this case, this is a catheter. सर अगर जो हम एंजियोग्राफी करते हैं तो बी इनसाइड द डाई वी ओनली सी द इनसाइड द ल्यूमेन व्हाट मीन इनसाइड बिकॉज वी आउटलाइन द डाई बट इफ यू वांट टू सी आउटसाइड द ल्यूमेन वी आर नोवेयर. So in that case we insert the catheter and that like this catheter go inside blood vessel and this gives total picture of the blood vessel, even out blood vessel, what is the inside blood vessels. So this is like a catheter torch. If we only see the road, that is called angiography. But if you want to see outside the road, like what is near side of road, like tree, rock, whatever thing, that is called intravascular ultrasound, which be needed in some type of complex procedure. Now we come to the rotablation. Rota means rotation, ablation means cut off anything. So sometimes we encounter the cases where there is a lot of calcium in blood vessels. So in that cases what to do? In that cases, last 3 years back, our department installed machine that is called rotablator. This is the machine where calcium is get cut by rotation, and in that catheter tip is rotated by catheter tip, which is diamond studded wire, that rotate with 1,80,000 revolution per minute. And if with higher speed they be insert in the coronary artery, and all of calcium get ablated from that. And this is the machine outside, where we can see the rotation, speed of rotation, what is the rotation get lower when this procedure get started. So you can see lot of calcium in the coronary artery, and this bar go to inside the coronary artery, the calcium get ablated, and there if pathway become clear, and later on stent was deployed in such type of cases. Now EP and RFA, we all know this is the now a flagship of our department. Maximum number of EP and RFA are done by our expert EP colleague. Now we come to the research paper and workshop. Total number of application in last 8 years is 48. Total number of workshop done for is 6. They are mainly done for pacemaker, CTO, bifurcation, and IVS. Now we come to the conferences. We all have 3 consultants. They are all academic talented. So they are usually going to present in the different type of cases, or giving go to different type of conference or talk. So this is the some conferences. We always have presentation in almost every conference in the respected conference in our country. Thank you, sir. Now we come to we invite to our senior resident who will present the case for today's CCR.
Good morning, respected teachers. Today we will be discussing a case about a 49-year-old female who came to us with the complaints of fever and weight loss. So starting with the history, a 49-year-old female resident of Bharatpur, Rajasthan came to us in OPD with the chief complaints of low-grade fever since 1 month, decreased appetite since 1 month, and weight loss since 1 month. The patient was alright 1 month back. Then she developed low-grade fever that was not documented by her, but it was continuous. It was more in evening than morning. It relieved with medication but reoccurred and was associated with generalized body ache. Patient also had decreased appetite. Patient gave history that she used to eat around 4 chapatis per day. Earlier decreased to 2 chapatis per day in the last few days. And also patient complained of weight loss by saying that loosening of her clothes were present. Patient had no history of cough, no history of throat pain, breathing difficulty, no history of diarrhea, vomiting, or burning sensation in urine, no joint pains or rashes anywhere in the body. A patient had no history of similar illness in the past and no history that was suggestive of diabetes mellitus, hypertension, any cardiac or neurological causes, or tuberculosis. Treatment history: due to the same complaints of fever and weight loss and decreased appetite since last 1 month, she had consulted outside to a local physician, a general physician. Routine blood tests and urine tests were normal. ANA was prescribed that came out to be positive qualitatively, and she was put on some antibiotic course and paracetamol for fever. A patient had no significant personal history. So to summarize, a patient, 49-year-old young female patient coming to us with fever, with evening rise of temperature, weight loss and decreased appetite with ANA positive. So what all possibilities we can think of as of now? First, because patient has come with fever, so infective pathology has to be looked upon. Because of low-grade fever, atypical pneumonia is the category we'll have to look in infective etiology. Because young patient coming to with ANA positive and non-specific symptoms, so inflammatory conditions like connective tissue disorders, SLE and rheumatoid arthritis, granulomatous disorders, sarcoidosis, tuberculosis, autoimmune disorders including vasculitis, these have to be considered upon. Neoplastic etiology like hematological lymphomas and also solid tumors also come with the similar complaints, and cardiac pericardial diseases, infective more commonly like pericardial effusion, pericarditis, restrictive cardiomyopathy. All the pericardial diseases also come to us with the similar complaints. So now coming to general physical examination, patient was conscious, alert, oriented to time, place, person. Height, weight and BMI were within normal limit. Pulse was regular. Normal volume and condition of the vessel wall with all peripheral pulses were bilateral, equal and palpable. Respiratory rate was 16 per minute, that is normal, thoracoabdominal nature. Temperature was 100 degree Fahrenheit when taken orally. Blood pressure, because the patient has coming to us with a history that is suggesting of a connective tissue disorder, so we took blood pressure in all 4 limbs. with appropriate size curve for both the upper limb and lower limbs. They were similar bilaterally and not much significant difference between upper and lower limb. But one finding that we found was during inspiration, the upper limb blood pressure, systolic blood pressure, fell down from 124 to 106. That is more than 10 difference in blood pressure was seen with inspiration. That was a positive finding. That is pulses paradoxus was positive. Jugular venous pressure when calculated was 9 centimeter water, negative small sign. That is a normal thing. And there was no evidence of pallor, icterus, cyanosis, clubbing or lymphadenopathy in the patient. Now coming to systemic examination, first cardiovascular system was examined. In inspection, there were no any significant finding. On palpation, patient was febrile to touch with apex impulse in the correct position, that is 5th intercostal space, 1 centimeter to the mid-clavicle line, that is a normal position. On percussion, increased cardiac dullness was found, that is the dullness was extending beyond the normal cardiac borders. On auscultation, S1, S2 were heard, but they were of muffled quality, and pericardial rub was heard in both systole and diastole in left lower parasternal border.
एक second, Doctor.
Yes.
Can you explain the normal heart sound, S1 and S2?
Yes, sir. S1, S2, these are two normal heart sounds that are S1, S2 are two normal heart sounds that are produced due to closing of the S1 is produced due to closing of the atrioventricular valves, mitral and tricuspid valves, and S2 due to closure of the cerebellular valves, that is the aortic and pulmonary valves. S1 is a low intensity murmur, whereas S2 is a high intensity and a low pitch murmur that is heard. So so sound.
So what they call?
Lub dub is
Lub
S1 and dub is S2
S2.
because of lower pitch.
Which heart sound correspond to the pulse rate, S1 or S2?
So the pulse rate is heard just after systole, and after systole the
Which sound correspond to pulse rate? Is it S1 or S2? This is my specific question. Your DM cardiology register.
Yes, sir.
Tell that.
So it will be heard with S1. The pulse rate will be heard with S1.
And what are S3 and S4 sounds?
So these are additional sounds. These are produced whenever non-compliance is formed into the ventricular cavities due to hypertrophy or dilatation. These are heard in diastole, that is when the blood is filling from the atria to the ventricles. Due to non-compliance, that is due to either hypertrophy or dilatation, blood turbulence is formed, is produced, that leads to additional heart sound production S3 and S4. S4 specifically due to atrial contraction part of the diastole that is heard in last part of the diastole.
ये मैं इसलिए पूछ रहा हूँ कि आजकल ऑस्कल्टेशन पार्ट छोड़ ही दिया है, ईसीजी और इकोकार्डियोग्राफी किया छोड़ दिया. But I request all PGs, whether they are medicine or cardiology or other branches, they should do auscultation of heart and auscultation of the lungs. कोई बात नहीं है, चीजें आगे बढ़ती रहती हैं, उनको सीखो, पर ये बेसिक जो चीज है ना, आई थिंक दिस व्हाट आई फील, जो क्लिनिकल सेंस है वो जाना नहीं चाहिए. ठीक, ओके.
The system examination were within normal limit, no obvious abnormality were found in them. In cardiology, we consider ECG and X-ray also a part of clinical examination, so these were also performed. ECG was showing in ECG, the findings we found were ECG. How do we describe ECG? That ECG was taken at a normal standardization, a regular rhythm with a heart rate of 115 beats per minute, normal axis. Morphology of P wave and PR interval normal QRS morphology and duration were found. Normal S3 segment and T wave morphology were there. Normal QT, the corrected QT interval was there. So the positive finding that we find in this ECG are the amplitude of the QRS complex is low. Low voltage complex are found in this ECG. Low voltage definition by definition, limb leads QRS amplitude less than 5 mm and the chest leads QRS amplitude less than 10 mm. That is the definition of low voltage complexes that we find in this patient. Another positive finding that we find is in the rhythm state, if we see, The amplitude of one QRS complex is less and second is more, then again less, then more. This is a phenomena called electrical alternance. So this is a positive finding in this ECG, low voltage complexes with electrical alternance. Chest X-ray PA view of the patient is showing cardiomegaly. So how do we calculate cardiomegaly? From the midline we calculate by calculating the cardiac ratio and thoracic ratio, cardiac diameter and thoracic diameter. Cardiac diameter is taken separately from the midline at the point of maximum bulging of the heart, both sides, left and right. Add that, we add both the dimensions and we get the cardiac diameter. And thoracic diameter we get by measuring the distance from the inner part of the outermost rib in the thoracic cavity just above the diaphragm. So when we divide that, if the ratio comes above 0.55, that is indicative of cardiomegaly, which we find in this patient. So to summarize till now, we have a 49-year-old young female patient coming to us with continuous low-grade fever with evening rise of temperature, weight loss and decreased appetite since 1 month. On examination, we are finding pulses, paradoxes, muffled heart sounds along with a pericardial rub, and low voltage complexes in ECG with electrical alternance and a cardiomegaly. So because of the presence of pulses, paradoxes, muffled heart sounds and pericardial rub along with low voltage ECGs, we are left with few causes of pulses, paradoxes. Infective have been ruled out, and connective tissue disorders largely have been ruled out. So cardiac causes which could lead to these things are pericardial effusion, the etiology of which could be tubercular malignancy or purulent, constructive pericarditis, restrictive cardiomyopathy, and respiratory causes could include bronchial asthma, chronic obstructive airway disease, and pulmonary embolism. Now on further investigation of the patient, CBC hemogram was showing microcytic hypochromic anemia with the hemoglobin of 10 gram per deciliter. ESR was normal, within normal limit. Electrolytes and renal function tests were normal. ANA profile we did because outside only qualitative was done, which came out to be positive. When we did it, it came out to be negative. Now coming to the 2D ecography of the patient. Next, that is the next investigation that we did. 2D echogram, this is a parasternal long axis view when the probe is kept over the sternum slightly towards left. This is showing, this is the left atrium opening through the mitral valve into the left ventricle, which is opening through the aortic valve into the aorta. This is the aorta. And this is the right ventricle of the patient. Beyond the left ventricle, this space, that is the pericardial space, which is showing fluid collection inside it, that is indicative of pericardial effusion. One common thing that we sometimes get, we also get confused while performing 2D echography is differentiating between pericardial effusion and pleural effusion. So one point of differentiation is in the parasternal view that we just saw, we have to look for the aorta, the thoracic aorta that we see here. If the effusion, the collection that we are confusing with, if it is in front, anterior to the aorta, it is indicative of a pericardial effusion. Whereas here in this case that we see, this is the aorta, descending thoracic aorta. If the collection is behind, posterior to the aorta, it is indicative of pleural effusion. So coming back to the previous video, this is the aorta that we see, descending thoracic aorta. The collection that we see is in front of the thoracic aorta, that means it is pericardial effusion. Other views are also done. This is a short axis view, again showing this is the aorta with the tricuspid valve seen. This is the right atrium opening through the tricuspid valve into the right ventricle, and this is the fluid collection seen around right ventricle. This is a 4-chamber view of the same patient. This is left atria opening through the mitral valve into the left ventricle, right atria opening through the tricuspid valve into right ventricle, and this is the fluid collection around it. And again, this is a subcostal view of the same patient showing pericardial effusion. So what we find in the 2D echography is massive pericardial effusion with early signs of tamponade, because RV was about to be RV was seen collapsing in the diastole part of the cardiac cycle. So impending cardiac tamponade. Patient is not in cardiac tamponade right now, but can go into cardiac tamponade. At present, patient is having pericardial effusion. So till now, provisional diagnosis that you have made is a pericardial effusion with mild microcytic hypochromic anemia. And now to find out the etiology of pericardial effusion, we will have to perform pericardiocentesis. General indications of pericardiocentesis are when the patient lands up to us in cardiac tamponade, massive pericardial effusion with RARV completely collapsing in diastole. Massive pericardial effusion more than either in size 20 mm or more than 500 ml. Hemodynamically unstable patient when the blood pressure falls, tachycardia occurs, then also we have to perform pericardiocentesis. Symptomatic moderate to large effusion, non-responsive to medical therapy, and in case of small effusion when etiology is undetermined. Pericardiocentesis can be done either fluoroscopy guided, UHG or echo guided, and CT guided. Fluoroscopy guided is now the safest and the most standard procedure which we do, because it helps us to confirm the space that we are entering while performing pericardiocentesis. So that is why it is the safest, but has the disadvantage of being X-ray based procedure. UHG and echo guided is easily available everywhere, therefore it is also done commonly, but chances of rupture are high because we cannot for certain be sure about the space that we are entering while performing pericardiocentesis. CT guided pericardiocentesis is also done. It helps us to tell us more about the chest and cardiac anatomy of the patient, extent of fluid collection, associated abnormalities in the chest, in the lungs and cardiac part of the patient, and also helps us in case of loculated effusions where the path while reaching towards the effusion can be difficult. But it also is very time consuming and is X-ray based. So now how do we perform pericardiocentesis? After taking proper consent and painting draping of the patient, what we have to do is, most commonly approach used is sub-xiphi-sternal approach, in which we insert a needle. After applying local anesthesia, we insert a needle between the xiphoid and the left costal margin, 2 to 3 cm inferior to the xiphoid process and 1 to 2 cm left of the midline. We insert it at a 45-degree angle aiming towards the left shoulder, and with a negative pressure cell ringer technique we insert it, and as soon as we reach the pericardial space, fluid comes. After we have reached the pericardial space, that can be confirmed on the fluoroscopy. We insert a guide wire. This is a thermo wire which is being inserted inside the pericardial space, and after insertion it takes somewhat of this shape, encircling the whole of the heart. This confirms that we are not in any one particular chamber of the heart and we are in the pericardial space, because the guide wire is encircling whole of the heart. It is not limited to only one side. The second structure that we see here, this is a catheter that we have placed through the right femoral vein of the patient through the IVC and into right atrium to measure the right atrial pressure. That we'll come to later. After ensuring that the guide wire is in the correct pericardial space, we advance a pigtail catheter over the wire and place a sheath and then aspirate the fluid. So this is a tracing. We have two axes with us. One is the catheter that we have placed through the IVC into the right atrium to measure the right atrial pressure. So this 107 is the heart rate of the patient, 93% is the saturation of the patient, 6/1 that is showing the right atrial pressure. That is in systole it is 6 and diastole it is 1, mean is 3, and via the sheath that we have placed into the pericardial space, we are measuring the pericardial pressure, that is 4. So this is showing that the right atrium is not collapsing completely, and therefore the patient, because the pressure of right atrium is more than the pericardial pressure, therefore the patient is not in tamponade right now and only in effusion. This was the fluid that we aspirated. Approximately 800 ml stroke fluid was aspirated, and post procedure echo showed thin rim of the pericardial effusion remaining. We leave a thin rim part. Yes, sir. Because in this patient had a large amount of pericardial effusion, we removed it. We keep the pigtail catheter in situ, because we don't know if reoccurrence of the effusion might occur. So when we leave the pigtail in situ, keep checking the echo daily. If for 48 hours there is no re-emergence of the fluid, then we remove the pigtail. Any disadvantage of taking all the fluid? Yes, sir. Because we we keep a thin rim of the pericardial effusion behind, because the pigtail that we are keeping inside the pericardial space, if we remove all the fluid, that would irritate the pericardium. That could lead to pericarditis and some electrical complications like AF, atrial fibrillation, and that is the reason that we don't remove all at once. Now we send the pericardial fluid for analysis, which showed a cell count of 400 cells with predominantly lymphocytic. ADA, that is adenosine deaminase, was raised protein content was raised 5 mg%. There was no malignant cells. Gram stain was negative, culture was negative, and AFB staining came out to be negative. The X-ray of the patient, this was the previous X-ray of the patient, pre-procedure X-ray, cardiomegaly, and this is the post-X-ray, and we see the clearing of the cardiophrenic angle. This is the cardiac phrenic angle that has been cleared because pericardial fluid has been aspirated, and this is the pigtail that can be seen that we have left inside the pericardial space. Post-procedure echo again showed that only a thin rim of pericardial effusion is left after the procedure. Again same, only a thin rim of pericardial fluid can be seen after the procedure. This was the report showing only mild pericardial effusion that we did next day. So now provisional diagnosis is mild microcytic hypochromic anemia with pericardial effusion, which was presumably tubercular because of the high lymphocyte percentage, ADA, and increased protein. Now reference was taken from respiratory medicine department. So what further we can do to confirm the diagnosis of tuberculosis, because nowadays we cannot start ATT without confirmation of the diagnosis. So now I'll invite Dr. Chhakshu from Respiratory Medicine to elaborate further.
Good morning, everybody, respected faculty members, dignitaries, and fellow residents. Thank you for giving me the opportunity to cover the respiratory medicine consult which was done in this case. Beginning with a quick recap, we're looking at a 49-year-old female who complained of fever, loss of weight, loss of appetite since 1 month. Her chest X-ray was suggestive of cardiomegaly, cardiac evaluation suggestive of pericardial effusion. Diagnostic and therapeutic pericardiocentesis was done and referred to the Department of Respiratory Medicine. For query tubercular pericardial effusion, as was very rightly discussed previously, that in a country like India where tuberculosis is an endemic disease, we have to rule it out first. Pericardial fluid analysis was suggestive of high ADA levels which were lymphocytic predominant. No AFB was seen on the smear and sterile aerobic culture. Pericardial fluid CB-NAT was done at our own lab, and the CB-NAT was positive in this case. This was the second case at Mahatma Gandhi Hospital wherein the pericardial fluid CB-NAT was positive, target detected, and rifampicin resistance was not detected. Pericardial TB was confirmed at a hospital with molecular testing. We have other diagnostic tests for pericardial TB. The gold standard tests are pericardial biopsy with histopathology, which demonstrate the caseating granulomas or acid-fast bacilli in the pericardial tissue. Mycobacterial culture or pericardial fluid or tissue culture, which is known as the MGIT culture or LJ media culture. It provides definitive microbiological confirmation but has a very long turnaround. It takes about 4 to 6 weeks minimum. So the supporting diagnostic tests these days we have are CB-NAT, which is the Gene Expert MTB RIF. It is a rapid test with moderate sensitivity in case of extrapulmonary samples. Adenosine deaminase more than 40 units per liter, which is highly suggestive in endemic areas, and in this case the ADA was 145. PCR based tests are TrueNAT, Gene Expert Ultra. It enhances the sensitivity for mycobacterial detection. And since culture and biopsy are not always feasible, a combination of clinical, biochemical, molecular, and imaging findings is often used in practice. This is the TrueNAT machine we have at our own molecular lab. There are 2 extraction systems and 1 quattro amplification system for MTB detection and rifampicin resistance at the same time in clinical samples in both pulmonary TB and extrapulmonary TB cases. CB-NAT, which is a cartridge-based nucleic acid amplification test, is a molecular diagnostic tool for tuberculosis. It is also known as the Expert MTB/RIF assay. It provides rapid MTB detection and detects rifampicin resistance simultaneously. It is a WHO-endorsed test for rapid TB detection and early treatment initiation. It reduces the diagnostic turnaround time compared to conventional tests. It is a battery-operated machine and can be used at peripheral centers, and we get the results in less than 2 hours. The difference between Gene Expert and TrueNAT is that Gene Expert is a cartridge-based test, and the TrueNAT machine we have at our lab is a chip-based real-time PCR. TrueNAT has a better yield as it targets the IS6110 and NRDB genes, and TrueNAT is a 2-step verification. It will only detect rifampicin resistance after detecting mycobacterium in the first place, whereas Gene Expert is a 1-step detection test. It will take more time because it will do both the things of detecting the bacteria as well as the sensitivity at the same time. In a lot of cases in our hospital, we see that the CBNAT reporting says that the test has detected the mycobacterium, but the rifampicin resistance is indeterminate. That is because of the low bacterial load. So we have another test which is ultra CBNAT. It detects bacteria as low as 16 colony forming units per ml versus 131 in the standard CBNAT. It enhances diagnosis in smear negative and in pediatric TB as well. It uses 2 RPOB gene probes for better identification of rifampicin resistance and reduces the indeterminate results which we often see. It has higher accuracy in HIV positive patients and extrapulmonary TB where bacterial loads are lower. And it is a superior alternative to standard CBNAT, particularly in high TB burden settings such as ours and difficult to diagnose cases. This is a diagnostic test comparison of CBNAT and LJ culture, where we see that the culture has 100% specificity, but it takes 4 to 8 weeks, and rest of the molecular tests, the timing is low, less than 2 hours, but the specificity and sensitivity is lower than the culture, of course. I'd like to discuss the Indian Index TB Guidelines 2016 for the extrapulmonary TB. They mention the diagnosis by the expert MTB molecular detection for rapid detection, pericardiocentesis or biopsy for pericardial TB. Treatment is a standard 6-month ATT regimen, adjunctive therapy with corticosteroids, pericardial TB management where we are focusing on preventing constructive pericarditis, and the key principles are to diagnose early, diagnose tissue-based tests and integrate HIV screening as well. In this case, the treatment advised was the standard intensive phase 2 months of isoniazid, rifampicin, pyrazinamide and ethambutol, and in the continuation phase were of 4 months where pyrazinamide was stopped. We added a steroid therapy in this case where it is recommended in the newer in the latest Indian Index TB guidelines, which is prednisolone 1 to 1.5 mg per kilogram per day for 4 to 12 weeks, and which can be tapered over 8 weeks to prevent constrictive pericarditis. Monitoring and supportive care is done by regular echos, follow-up of effusions, and to manage HIV if present, and malnutrition and other complications if any caused by ATT. The goal is to prevent complications like tamponade and constriction and ensure complete recovery. The question is why steroids? Why would we like to give steroids in such case? So they are given to prevent constrictive pericarditis, which reduces fibrosis and long-term complications. It reduces inflammation and effusion, so helps in faster resolution of the pericardial fluid. It improves symptoms and outcomes, lowers mortality, and enhances patient recovery. Steroids are also given in other forms of extrapulmonary TB, such as miliary TB, endobronchial TB, laryngeal TB, adrenal gland TB, TB meningitis, and adrenal crisis. Thank you. So in a lot of hollow organs TB, steroids are advised to give. So to prevent stenosis, to prevent fibrosis, steroids are advised. Yes, sir, we do. Yes, sir.
There is no guidelines for any steroids, possibly because much space we have.
Yes, sir.
In the previous slide, go to the previous slide. You said the continuation phase is 2 drugs. No, next please. The treatment. In the previous. So continuation phase is always 3 drugs.
Yes, sir.
And in continuation of what Dr. Nijavan asked, what is the evidence for use of steroids in pericardial TB? Because for peritoneal TB there is very, very little evidence, which is also almost 40 years old.
So there are a lot of meta-analysis which have confirmed that the use of steroids in pericardial TB, which is a form of extrapulmonary TB, the patients have had better follow-ups in cases of the effusion development again and again, recovery, and the development of constrictive pericarditis as well. That is why it is recommended in the Index Guidelines 2016 now.
So there is good evidence.
Yes, sir, there is a definitive guideline about that.
So after the consult, the treatment that we started was anti-tubercular treatment. Isoniazid was giving 300 milligram per day, rifampicin 600, pyrazinamide 1500, and ethambutol 1000 milligram based upon the weight of the patient. Steroid was started, tablet prednisolone 60 mg once a day. Baseline LFT was taken, that was normal. And after 2 days of continuous checking that the patient did not develop re-emergence of the pericardial effusion, we discharged the patient after removing the pigtail and advised high protein diet. That is a part of any tuberculosis patient. For the course, the patient was kept on 4-drug regimen as advised for 2 months and later switched to 3 drug. Prednisolone was given 60 mg every day for 1 month. After that, it was tapered over next 1 month. The patient had clinical improvement. Fever was subsided just after 2 days of starting ATT, and from the second week onwards, the appetite improved and weight gain also improved, and similar improvement was seen in pericardial effusion. Patient developed moderate gastritis and nausea, and that was managed with pantoprazole and domperidone. In the follow-up, patient is with us. 5 months have passed since starting of ATT. Patient on continuation phase. Clinically, there is no symptoms at all, and echo is showing no effusion without any signs of constructive pericarditis, no shiny or calcified pericardium, and no effusion. So the reason for selecting this topic was because National Tuberculosis Elimination Program guidelines now state that without confirming, we should not start ATT. And this is important part because limitations of tests that we have.
So if you go by guidelines, then
Yes.
what if the diagnosis is not true, but we have clinical stuff?
Yes, sir. Like we said, see,
They must be gold standard evidence. And what is proven tuberculosis according to the national guidelines? Do the molecular test count as proof, or it has to be histologic, or?
no, the molecular tests also do count as proof. Even at if comes positive, that can be done.
When you say that you proven TB, please spell out what is proven TB.
Okay. On the basis of either the molecular testing, CBNR gene expert that we do, or on the basis of culture, LG media culture that we do, or histopathologically that shows AFB staining.